Just
Yes.
introduce this panelist. So I'll welcome you on behalf of the Department of General Medicine for a second interdisciplinary forum webinar. I would like to welcome our senior consultant cardiologist from our TKMCC, Dr. Balamurugan sir, as well as our close friend, one of the part of the family, Dr. Davis Prabhakar, who is a consultant in medical gastroenterologist, has interest in endopediatric and other nutrition health. I welcome you all for again this second interdisciplinary forum. I hope Bhaskar sir will join us in the due course. Over to you, sir.
Okay, thank you, Dr. Arun Kumar, for a nice introduction of the speakers. So, as you all know, that this interdisciplinary forum has been initiated to facilitate the multiple disciplinary approach into a single case and arrive at a single decision. So, this is a webinar 2 of our webinar series. And actually, this is a very good case. This is a case, young male developed cardiac failure, and simultaneously he developed liver problem also, hepatitis, with the enormous elevation of bilirubin. Whether this cardiac failure and liver cell problem are correlated or coincidental or simultaneous in onset, or these are interlinked, whether this liver problem is due to cardiac failure or the cardiac failure is causing this liver problem, we are going to discuss. So we have the experts, we have medical gastroenterologists and cardiologists are here. So we'll start the discussion. The PG will first present the case. So the first part will be the cardiac problem. So the Balamurugan sir and Badshah sir will discuss. They can intervene the postgraduate by asking questions. The postgraduate presenter is free to answer the question. So remember, the presenter is not able to answer or is not knowing the answer. Other PGs are most welcome to answer. So let it be interactive session. So not a one-to-one reaction. So that will not be useful for others. So let the other PGs also taking part in this discussion. So with this introduction of the case, over to the presenter and to the panelists, Dr. Davis, Dr. Balamurugan, and Dr. Badshah.
Thank you, Raja.
Good evening, sir. Thank you, sir. Moving on to the presentation, sir. A 32-year-old male patient who is a mechanic at Chennai by occupation, hailing from Thoothukudi, brought to the hospital with chief complaints of breathlessness for the past 1 week and bilateral lower limb swelling for the past 1 week. History of wrestling illness. The patient was apparently normal 1 week prior to admission, after which he developed history of breathlessness in the past 1 week, which was acute in onset, progress from NIHA 2 to 3, aggravated on exertion, relieved on rest, associated with orthopnea. History of bilateral lower limb swelling.
Shall I intervene like exam? Radhel sir, can I intervene between history or?
Yes,
definitely can intervene.
Some basics questions. Shall we ask some basics questions?
Yeah, sure.
Manoj, can you elaborate NIHA classification? For exam purpose, we'll discuss something in symptom analysis. NIHA.
NIHA class 1 is no symptoms addressed, sir. NIHA class 2 symptoms with severe exertion. Class 3 symptoms with minimal exertion. And class 4 is exertion addressed, sir. Symptoms addressed.
This is how it is described in Harrison. So you should use the exact words what is used in your textbook for NIHA. This is a very important symptom analysis in cardiology. So you should use what the exact terminology used in the book. They used physical activity and ordinary activity. These two words should come like. So class 1 is no dyspnea address. Class 2 is ordinary activity causes dyspnea, palpitation, fatigue, or mild
limitation of physical activity.
This is class 2. Class 3 is marked limitation of physical activity. Less than ordinary activity causes symptoms. Class 4 is dyspnea address. So you use these two words, that ordinary activity and limitation of physical activity. This is very important in classifying NIHA classification. Okay, go ahead.
Okay, sir. History of bilateral lower limbs. History of bilateral lower limb swelling for the past 1 week, which was progressive, painless, and up to knee. History of reduced urine output. He noticed a low circulation of ice for the past 1 week. History of abdominal distension for the past 1 week, uniformly distended, followed by leg swelling. History of black colored stools for the past 3 days. No history of chest pain or palpitation or syncope. No history of cough with expectoration or hemoptysis. No history of hematemesis or hematuria.
So is there history of orthopnea on PND?
Sir, there was history of orthopnea and PND, sir.
Why you skipped orthopnea on PND? Because these two are Stalin signs of hepatitis. So
these are specific for cardiac cause of breathlessness, sir.
Okay.
PND is more specific for PND is more specific than orthopnea. Both suggest breathlessness is probably due to cardiac cause, sir.
Cardiac cause, generalized. What does PND indicate?
PND indicates breathlessness after 2 hours of going to sleep. The patient wakes up in the middle of the night, and only then the breathlessness will be relieved, sir. But orthopnea, after lying for about some 10-15 minutes, the patient will start getting breathlessness, sir.
What is the mechanism of PND?
In PND, there will be during sleep, the venous return will be very much increased, sir, due to lying down supine position, increased venous return, and the diaphragm is also elevated, and the sympathetic tone will be somewhat hampered, sir. The increased cardiac return cannot be handled by the heart in failure. So patient gets sudden onset breathlessness in the middle of the night, sir.
So why it happens after 1 or 2 hours going to bed? Doesn't happen immediately.
Sir, the venous return probably peaks after.
It's not venous return. This is redistribution of the extravascular blood and fluid into the intravascular compartment and interstitial compartment. So it takes some time. It's redistribution of the blood from extravascular to intravascular space. That simulates it causes interstitial edema, that pulmonary venous congestion, and thereby dyspnea. Okay.
Okay, sir.
I have a question for you, Dr. Manoj. See,
Yes,
you're
sir.
saying some yellowish discoloration of the eyes, no? So, and you're
Yes.
also talking about abdominal distension, some black color. So what are you trying to,
Yes, sir.
what information are you trying to give over here?
Sir, there could be some underlying liver pathology. Since the patient himself is a known case of DCM and DCM, this could be due to cardiac cirrhosis, or the patient is
Why
a
are
known
you directly
alcoholic.
jumping to cardiac cirrhosis at this point of time? You're only in the history, right?
Yes, sir.
Yeah. So you're telling me that this jaundice, everything is there only for 1 week. Was it prior there before this? No.
Patient doesn't know, sir. Actually, he noticed the discoloration only for the past 1 week.
Then how
But
are
the
you
patient,
terming it as cirrhosis right now?
since the
You're
patient is a
saying
known
there
case
is
of
no
DCM,
past history of liver disease, right?
yes, sir.
Then was the patient taking any medication for liver disease prior to this?
No, sir. Patient was on irregular medication, sir.
Was he taking? So that means he was taking something for liver disease?
Sir, he was suggested some medications at his prior admission, sir.
So
He
you're
was
not sure exactly whether it is an acute onset of liver disease or it's a chronic thing. That's what you're trying to tell me, right?
Yes, sir.
Okay. So you can't term it as cardiac cirrhosis at this point of time. You need more information to say it is cardiac cirrhosis, right? And
Yes,
you're
sir.
telling me about the black colored stools, right? So what are you talking
Yes, sir.
about there?
Sir, black colored stools would be probably due to it is maybe melena, sir. But
Yes,
there
no,
may be some
maybe it is
underlying drug
melena. There's
induced
no other diagnosis for black color stools. You have to say only melena. Okay,
yes,
so why you think this melena could have happened?
due to upper GI bleed, sir.
Very good, excellent. So upper GI presents as melena. Lower
Yes,
GI
sir.
bleed, what is the word you will use?
Hematochezia, sir.
Hematochezia, right. And tell me, in any upper GI bleed, can you have frank blood coming via the rectum?
Yes, sir. If the transit is very fast, or if the
What is
patient is
fast?
having a
What is fast?
fast transit time, sir.
Okay, or massive GI bleed.
Massive GI bleed can present
Exactly.
with
So how much of massive GI bleed is said when you have frank blood coming out of the rectum?
sir, if it is more than 600 ml in 24 hours.
Excellent, excellent. Very good. That's all. That's the answer I want. So anything more than 500 ml, the patient can even have a massive bleed. One more question here you should have asked is, From history, you can find out if the patient is having a mild or a moderate or a severe bleed. What are the questions you would like to ask? You
Sir,
got my question?
yes, sir.
See, you're saying black color stools. You're saying the patient is having GI bleed. Very good. Excellent. You've done a good job. You have found that answer. But now, from the history, how will you find out if it is a mild bleed, a moderate bleed, or a severe bleed?
Um,
Okay. So, how
yes,
can
sir.
you find it is? One is by quantity. You can ask the patient, எவ்வளோ போச்சின்னு you can ask, or எத்தனை வாட்டி போச்சி. The other question you can ask is, in mild GI bleed, the patient will say, I'm having postural hypotension. அப்படின்னா என்னது?
Patient feels giddiness on standing position, sir.
Excellent.
Lying down.
So what happens when there is no blood in the body? What happens? Naturally, you will tend to have hypotension.
Yes, sir.
The other thing is, the attenders will say, massive or bleed அடிச்சது, massive or hematemesis or melena ஆச்சு, patient had LOC. If patient
Yes,
presents
sir.
with LOC, you know the patient has lost more than 2 or 3 liters of blood. Okay. So
Yes, sir.
whenever you ask for bleed history, make sure you ask the quantity and the stories like LOC, stories like, what do you call that? Postural hypotension. இதெல்லாம் you must definitely ask. Right? Okay. Proceed.
There was no history of chest pain or palpitation or syncope, no history of cough with expectoration or hemoptysis, no history of hematemesis or hematuria. There was no history of fever, no history of abdominal pain, vomiting, and loose stools, no history of altered sleep pattern, no history of headache, no history of any involuntary movements or behavioral disturbance.
I'll just ask you something here.
Yes.
You said loose stools. What do you indicate in loose stools here? You just now told me melena.
Yes, sir.
So why the word loose stools is coming here?
Sir,
No, what information you're trying to give me? I just want to be clear. I just want to be.
whether there is any infective pathology for in the GI tract. Sir.
So you're trying to connect the heart and infection or liver and infection? See, when you said loose stools, only one thing. Okay, I'll ask you a more simpler question, right? So coming in GI, coming to stools, you have melenic stools and you have stithoric stools. Okay, so which
Yes,
condition you will have melenic stools? You have already told me, UJ bleed. Which condition you will get stithoric stools?
Sir, obstructive jaundice.
Obstructive jaundice. Okay, anything else more common?
Pancreatitis.
And that's the answer. Excellent. So, stools la ரெண்டே ரெண்டு தான் கேட்கணும். When you say loose stools, I will immediately think of stithoria தான். Oily stools ன்னு நினைப்பேன். So, don't bring that
Yes.
here. If you bring that
Okay, sir.
here, it diverts. Okay, so don't talk anything about the loose stools over there. Okay.
Okay, sir.
One more thing, if you had mentioned clay colored stools, I would have felt a little more happier because in jaundice you are expecting clay colored stools.
Clay colored stools.
Excellent. Okay. So 3 types of stools, remember: oily stool, clay colored stool, and melenic stools, right? So in the morning, you should know where it happens. Okay.
Okay.
Okay. Then I think the next slide goes further to the past history. You have not given me
Yes, sir.
any more information about the liver disease. I would like to know more information. You said about urine output and all, something you were telling, right?
Yes, sir.
So there's reduced urine output?
Yes, sir. There was reduced output, sir.
Okay. Now tell me whether it's reduced urine output or high colored urine output.
Sir, patient told it was reduced output, and when we catheterized, we found out he had some high colored urine, sir.
Oh, so it was more like a jaundiced urine. Can I take it like that?
Yes, sir.
Okay, fine. Excellent. Then I would like to know the other things. What are the other jaundice related history you would like to ask? These are all basics. You should know these things.
Yes, sir. Sir, in the I'd like to ask regarding any itching is there, sir.
Itching. Very good. You have nailed it. Okay, good. So what are you indicating with itching?
Itching indicates pruritus due to obstructive jaundice, sir.
Cholestasis. That's the word you should say.
Cholestasis.
You should not say pruritus. You should not say obstructive jaundice. All these words are all later on technologies, not now. Now, at this point of time from history, you should only tell me cholestasis, right? Then
Okay.
anything else you would like to ask?
Sir, in the past history, I would like to ask.
No. We are still in HOPI, history of presenting illness. Past history la vera questions irukku. You would like to ask any prodromal symptoms. Why? What are prodromal symptoms?
Sir, fatigability,
Excellent. Why? Why would you want to ask that? What disease am I thinking of related to the liver?
Could be a
Which
case
can cause
of
jaundice? Which is associated with fever? I'm giving you a lot of clues. Fever,
viral
jaundice.
hepatitis. Could be viral
Excellent.
hepatitis.
That's it. That's it. So all these has to be asked. Okay. Then you should ask about EC fatigability. We already discussed about that, right? So patient having
Yes, sir.
postural hypotension. So anemia symptoms keklam. Then the other thing you should ask is about okay, the liver is also responsible for vitamin deficiencies, right? So one thing you would like to ask the patient.
Sir, if there any bleeding manifestations?
Okay, you're
From,
talking about coagulopathy. Am I right?
yes, sir.
Okay, fine. Anything else? I would like to talk about vitamin A deficiency. What will you ask?
Sir, you can ask for bite or spots or any visual
Bite or
disturbance.
spots. You'll ask the patient whether you are having bite or spots. That is a symptom. This is a sign.
Yes, sir.
You will ask for night blindness.
Night blindness.
You will ask for night blindness, right? Then easy bruisability. That's the word you should use. Okay, coagulopathy ki easy bruisability, right? So all these things, make sure to ask in anything related to the liver. These are 7 questions should be definitely asked. Itching, fatigability, then urine output, prodromal symptoms. One more thing, very important, fever. Will you think of fever? Fever and jaundice, one
Sir,
more condition other than viral hepatitis? The question is open
tropical
for everyone.
fevers.
Anyone can answer. You can put it up in the comments also.
Tropical infections.
Why are you complicating? Keep it simple. You are talking something about obstructive jaundice, right? What is
Yes, sir.
obstructive jaundice? What is that one word I'm looking for?
Direct bilirubin, sir.
Very simple, man. Obstructive jaundice la enna varum? Bile is stuck up, right?
Yes, sir.
Now what happens when too much of bile is stuck in the biliary tree? Patient goes for dash.
Cholangitis.
Cholangitis. Very good. Can you name the triad associated with cholangitis?
Charcot triad.
Yes, Charcot. Somebody said it. That's the answer. Charcot triad. So can you tell me the components of Charcot triad?
Sir, right hypochondriacal pain.
Good.
Fever.
Yes.
And a jaundice.
That's all. Okay. Yes, proceed. You have done well so far. Good. Continue.
Manoj, you said abdominal distension, leg edema, dyspnea. So tell me in the chronological order of dyspnea, abdominal distension, and leg edema. So which came first, followed by which, followed by which?
Yes, that's a good question.
Sir, patient noticed leg swelling followed by abdominal distension, then dyspnea, sir.
Then dyspnea. So fine. See, he didn't have dyspnea initially. So
Dyspnea
was
worsened in the past 1 week, sir.
initial complaint, or pedal edema was the initial complaint?
Patient had some underlying dyspnea, sir, in the past month or so, but he had developed excessive breathlessness in the past 1 week, sir.
So I'm just asking, how will be this pattern in cardiac failure and liver disease? That's all. Tell me. Cardiac failure la eppadi irukum, liver cell failure la eppadi irukum?
In liver cell failure, there will be abdominal distension followed by leg swelling. Then the patient gets breathlessness, sir.
Okay. Cardiac la?
Then in cardiac, the patient will develop breathlessness. Then he'll have leg swelling and abdominal distension, sir.
So any cardiac condition that violates this law?
Constitutive pericarditis.
Why?
Sir, because
The concept
due to right heart failure,
have mechanical effect on the hepatic vein draining into the IVC-RA junction. So it consists that part that so hepatic segmental hepatic dysfunction happens and ascites comes.
Okay.
Okay.
Then Manoj, what about facial involvement?
Ascites precox.
What about facial involvement in liver cell failure and CCF?
Sir, there will be the face will be emaciated, sir. There will be fat loss and in
So
Can
liver
cardiac
you
failure is
correctly
always
mention it?
dependent.
Sorry, sir.
Cardiac failure is always a dependent edema. The patient is supine or bedridden, it will start from the sacrum. But if the patient is ambulant, it will start with the lower limb and then it is ascending edema. But liver cell problem is not like that. It always starts with ascites and then descends down. And it never ascends up above the costal margin. So it is very, very rare to involve face in a case of cirrhosis or portal hypertension or liver cell failure. So that is the differentiating feature in the history. Okay. Right, proceed.
Okay.
So here you should always talk about facial features of liver. You should always tell temporal wasting. That is one thing which we always look for. Temporal wasting
Okay,
always that means that fellow is severely protein malnourished. And I still remember Rajavil's teaching paucity below,
Poverty,
sorry, paucity
po-
above and plenty below.
poverty above, prosperity
Oh
below.
yeah, I still remember that. Rajavil sir used to teach that. I still remember that. So that is a very good way to remember how the ascites progresses. Yes, I think we can proceed further.
so moving on to the past history, sir. Patient is a known case of coronary artery disease and dilated cardiomyopathy and had undergone PTCA to LAD 1.5 months back, sir. So along some 1.5 months back and not on regular medication. History of liver disease for the past 1.5 months, sir. Patient is not a known case of type 2 diabetes mellitus, hypertension, bronchial osmosis disorder, or tuberculosis, sir.
Okay. Here I would like to just stop you for a minute. You said some history of liver disease.
Yes,
What
sir.
do you mean by that?
Sir, patient's records were not properly available, sir.
Forget the records. You're talking to the patient for the first time. Just let us say he doesn't have any records. Some past history you can actually elicit from him. What are the past history you would like to elicit from him?
Sir, whether there was, I would like to look for the etiology, sir. Whether patient is alcoholic or a known case of hepatitis B or C.
Patient is from a gramam. He doesn't know what is BC.
Whether there was any pruritus, I would like to ask regarding
Pruritis
his
comes in history of presenting illness. We are done with that, bro. Now we are going forward. Past history na ennalam kekkano. Few 3
history
4
of tattooing, blood transfusions.
Very good, excellent. Tattooing, good. Then what you are thinking of tattooing?
Needle sharing of needles
What
could lead
disease?
to hepatitis B and C.
B
Could be
and C
possible.
illa. No, it's not B and C, it's only C. Okay, C more than B. That's how you should say, right? Okay. Then அடுத்தது என்ன கேப்பீங்க?
Whether there was any blood transfusion history, sir, regarding
Okay, right. Again, B and C. அதுலயும் சேர்த்துக்கலாம். அடுத்தது.
native medication history, sir.
Excellent. That's the word. So it's called CAM intake. What is CAM? CAM. Complementary alternate medication. So all your homeopathy, all your siddha, all this pachayalai, whatever these patients are taking now, all this comes under CAM intake. Okay. That is when another thing is, one more thing you should ask related to that. இங்க போடுவாங்களே பாத்திருக்கியா கையில போடுவாங்களே
IV drug abusers.
branding. You have heard of that? Branding. You have never heard of it? சூடு வைப்பாங்க தெரியுமா? You have not heard of it. Okay, that's because if you work in the liver unit, you will know it. நிறைய பேர் வந்து from கிராமத்துல they'll come சூடு மார்க்கோட வருவாங்க. The general belief in the village is சூடு வச்சா some sort of branding they will keep. It's called branding. சூடு வச்சா jaundice மஞ்சக்காமல சரி ஆயிரும். That is the general term. So you should look for marks of tattooing as well as branding. சூடு வச்சா சரி ஆயிரும். Childhoodல நிறைய small kids will have it in their hand. Okay, so you should look for marks of branding. You should look marks of tattooing also. Then one more thing you should think about is past history of surgeries. Okay,
Yes,
now it is not very important because the National Viral Hepatitis Program is very good. All the children are being vaccinated, so it is not a problem. But before 1985 or 80, if the patient has been undergone a surgery or a blood transfusion, definitely he has to be thought about hepatitis B. You got it? And
yes,
one
sir.
thing very important, childhood jaundice. சின்ன வயசுல மஞ்சக்காமலாம் வந்துச்சா? Did the
Sir,
jaundice recover it on its own? Or was any treatment given? So if a jaundice has recovered on its own, what will you think of?
Could be hepatitis A.
Excellent. Hepatitis A. If a jaundice that has waxing and waning, வந்துட்டு போகுதுன்னா, what will you think of? Something more severe. Maybe PSC, PBC, something like that you can think about. Okay, so intermittent jaundice, something like that they will say. Okay, so make sure past history la verum liver disease and oru vaartha podakudadu. At least you should take the effort to ask these 4 5 questions. These are all very common. CAM intake is very common. Tattooing is very common. Needle abuse is very common. All this you should ask. Okay, yeah, you can proceed.
Yes, Dr. Manoj, the point raised by Dr. Davis was an excellent point. Okay, so in this case, so we should have an interdisciplinary approach. So biggest question in this case is cardiac failure and liver cell problem, they are simultaneously occurring or they are etiologically, right? So whether the cardiac failure caused liver cell failure. So for that point, you should probe more history in the past history, because you are just told CAD for 1.5 months. So CAD 1.5 months, whether the problem started 1.5 months only or earlier, 2 months back or 3 months back, then and there the patient had symptom and went to the hospital then and there and treated in a local hospital like that. You should have a more probing questions to the patient to bring out more past history. And then liver cell problem was highlighted by Dr. Davis. So understand all the pages, please note this point. So past history, if you are able to bring out more history, more points, more symptoms rather than this single word CAD, PTCA and like that. Symptom wise, you should have probe. So that will bring more spotlight on our $1 million question. Okay, you can proceed.
So the personal history, patient consumes mixed diet, appetite is normal bowel and bladder habits, chronic alcoholic for the past 10 years and chronic smoker for the past 10 years.
I think I should stop you here because my favorite word alcohol is here. Yeah. So again, I'm telling you, and alcohol means I am a teetotaler, but since alcohol is my field, I am talking about alcohol here. See, this word chronic alcoholic is actually abusive towards alcoholics. I mean, I shouldn't say the word. What is a new term we are using for them? See, a physically challenged person, you can't say handicapped, right? You say
Yes,
them
sir.
as physically challenged. அதே மாதிரி மென்டலில் வந்து மென்டலி சேலஞ்சுன்னு சொல்கிறோம், ரைட்? அதே மாதிரி இனிமேல் யூ கான் கால் அ குடிகாரன் as alcoholic. What you should call them as?
Alcohol dependence syndrome.
No. No.
Alcohol use disorder.
Yes, that's the answer. They are all alcohol use disorder patients. புரியுதா? So any alcohol user you use, give some respect and call them as alcohol use disorder. The term alcoholic is gone out of fashion, right? Now you tell me one thing. You said bowel and bladder is normal, right? But just now you
Yes,
told
sir.
me the patient is having urine output less, patient is passing melena. Then why are you saying bowel and bladder is normal here? It's again deviating, right? You're getting my point?
Sir. Yes, sir.
See, you are targeting towards liver disease. So don't bring unnecessary words like bowel bladder. Just don't comment about it. Just don't comment about it in the exam, at least for the exam's sake. Yeah. Then you said about alcohol. You said 10 years of alcohol, right? I
Yes,
would
sir.
like to know when was his last drink. That's very important.
Sir, his last drink was around some 1 week prior, sir.
You should mention that. Okay. So when you say a patient is an alcohol, 3 questions you should always ask. First question you should ask is, how much of alcohol does he take?
Yes,
Quantity. Quality. What sort of alcohol he takes? Third thing is, when was the last drink? These 3 things are very important. Purida? So never ever forget that. Why na? It gives us information. It gives us a lot of information. Why na? When we say how much of alcohol he takes, we can actually calculate the gram of alcohol. So what is the normal, what is the safe limit of alcohol for anyone? I'll give you a one standard drink. கேள்விப்பட்டிருக்கீங்களா?
Yes, sir.
How much is one standard drink?
Sir, one standard drink is 10 to 14 gram of alcohol, sir.
Excellent. 14 grams. Round out number. We'll keep this on. Okay. So for men, it is how many standard drinks allowed for men?
Sir, up
2
to
to 3. Okay. Women 1.
okay, sir.
சரியா? That is provided. ஏன்னா if you take one standard drink, அது from brand to brand it will change. Whiskey 30 grams, beer 250, wine 100. It varies. Okay. But remember, the safe drinking of alcohol is one standard drink for men, one to two standard drinks for men, and for women it is only one. சரியா? What is the word binge drinking? Can you tell me that? What is the word? Have you heard of the word binge drinking?
Yes, sir.
What is the meaning of the word binge drinking? At least colloquially, what you know about it in Solong. You don't have to give me the exact definition.
Sir, patient consumes alcohol continuously over the past few days or.
Okay, good. Yes, you're right. So, இன்னும் கொஞ்சம் இதா சொல்லணும்னா more than 4 to 5 standard drinks within 2 hours. அதான் binge drinking. புரியுதா? So if I take a standard drink per day, nothing big might happen. But if I binge drink continuously, I might end up in alcoholic hepatitis. Right? So all these things are very, very, very useful. I mean, very important whenever you ask alcohol. So history வந்து இன்னும் கொஞ்சம் you have to probe in deeper. புரியுதா? So alcohol ன்னு சொன்னா இந்த மூணு terms definitely வந்தே ஆகணும். புரியுதா? Then in personal history, again, you should ask about tattooing, drug abuse, and also whether multiple sexual partners irukangalaanu. Okay, so these things you keep it in personal history. Okay, right, proceed.
Okay, sir. There is no family history of similar illness, sir.
Okay.
And moving on to general examination, patient is conscious oriented, moderately built and nourished. Hydration is fair, afebrile, pallor present, icterus present, no cyanosis, clubbing was present, no lymphadenopathy, bilateral pitting period present up to knee, sir.
Manoj,
Yes.
how can you find out anemia in the presence of jaundice clinically?
Exactly. That was my question here. Good.
Sir, you can look for tongue was a bit pale, sir.
Okay, leave it to Davis, sir.
Yeah. See, it is very difficult. See, okay, before we go to that, can you tell me what are the types of jaundice that you can see in the eyes? Based on color? You know, right? We can grade jaundice just looking at the eyes. கண்ணை பார்த்து கதையை சொல் மாதிரி.
Lemon yellow, orange yellow, and greenish yellow.
Greenish yellow. Okay, fine. அதெல்லாம் ரொம்ப எக்ஸ்ட்ரீம். Greenish yellow லாம். One more thing is there, muddy. Muddy is normal, huh? Muddy conjunctiva is normal. Okay.
Normal.
So orange yellow, lemon yellow is mild. அதுக்கப்புறம் மேல போகுது. Okay. But it is very difficult to identify pallor in the presence of such high bilirubin jaundice. It's very difficult. Okay. If at all you want to see, if you are saying I'm going to look at the palms or I'm going to look at the tongue, everything will be yellow. You cannot assess pallor. It's very difficult to assess pallor. Okay. In this case, if you want to assess pallor, how we do it is when we do an endoscopy, we look at the mucosa. If it is very pale type of mucosa, we know the patient is anemic. That is one way we find out. Right? So finding anemia, finding pallor in a case with icterus is very difficult. So the minute you put a chart like that, people know that you don't know how to identify between anemia and icterus. Pallor and icterus. Right? So don't mention about icterus and mention about pallor in a case of icterus. Right? Okay. Anything else you would like to talk about in this slide regarding liver disease? Again, I told you, right? History is important. Now your eyes are important. Your mouth has stopped talking. Now your eyes. So what is one thing I would like to look liver disease in this patient?
Bite out spots.
Very good. I will look for bite out spots. Okay. Arthadu?
Subconjunctival hemorrhage, sir.
Subconjunctival hemorrhage.
Eyes, KF rings.
KF ring with your naked eye you can see, yeah? Abdiya, you're having superhuman eyes, huh? Yeah. So what all? You can look, see, only you just tell him to remove his shirt and sit in front of you. So much of information is there. Okay? But
yes,
all your liver cell failure marks, you know that, right?
Yes,
all your liver cell, other than that, one thing I would like to look is, I will look at his back and I will look for scratch marks. Why?
To look for any, as a marker of pruritus and dryness of skin.
Marker of pruritus, marker of cholestasis. Yes. Marker of cholestasis, I will look for pruritus. And most this sort of pruritus will happen not in your periphery, it will happen only in the core, central. So these patients will have one big kuchi where they can be sitting and scratching. You can see the scratch marks behind their backs. Okay. Another thing is I will look at their nails. Why? How will the nails be in a CLD patient who has pruritus?
White nails, sir. Half
white nails. One more word. White.
Half and half nails.
White. Shiny nails. Okay. What happens when you continuously do like this? What happens? Your nails become polished and it becomes shiny. So look for white shiny nails. Purida?
Okay.
Okay. Good. Then proceed.
There were no markers of congenital heart disease, infective endocarditis, rheumatic fever, tuberculosis or HIV. No markers of liver cell failure. Fundus examination was normal, sir. Vitals examination, pulse rate 1 or 2 beats per minute, regular rhythm, feeble, No specific character, felt equally in all peripheral arteries bilaterally, no radial or radiofemoral delay, no vessel wall thickening. Blood pressure in the right upper limb was 70/50 mm Hg. The left upper limb was 70/50
Dr. Manoj,
mm. Yes, sir.
Sorry to disturb. Kannan Baba sir has raised one question in chat box. Role of pharma increases intensity in identifying the pallor in jaundice.
Sir, if it is less than 7, the palmar crease will be very much will not be very prominent, sir.
Usually palmar crease, what is the role of palmar crease? Why to look at the palmar crease?
Severe anemia, in case of severe anemia, the palmar crease will be will not be very prominent, sir.
Prominent, you should not talk like that. So color of the palmar crease compare with the adjacent area. Okay, so adjacent area. Usually the color of the palmar crease is darker than the adjacent area. So if it is equal to the adjacent area or lighter than the adjacent area, you can say it is a severe anemia or it is a pallor. So that is a valid point in identifying pallor in the presence of jaundice, because by looking at the eyes, you will be confused whether it is anemia or jaundice. And another thing is that anything missing in the general examination, any other PGs can respond, apart from what Manoj have told. So very important thing in the liver cell problem or any GIT case or any chronic cardiac problem, you should give weightage to the nutritional markers. You never mention any nutritional markers. So all the nutritional markers from head to foot, and also anthropometric markers. You said just moderately nourished. So how will you say moderately nourished without looking at the BMI or without looking at the waist to hip ratio? That is also a marker for cardiac problem. Recently, that is the best marker for coronary disease. Okay, so waist to hip ratio, mid-arm circumference, and then the BMI. These you should calculate. And then the nutritional markers from head to foot, starting from anemia, jaundice, and a bite spot, and neck pigmentation, and knuckle pigmentation, angular stomatitis, sclerosis, bald tongue, magenta tongue. Okay, so these are the things you should look at in all cases of liver cell problem, because most of the liver cell problem will have this nutritional deficiency. Okay, proceed.
Blood pressure in the right lower limb was 70/50. Blood pressure in the left lower limb was 70/50 mm Hg, sir. Respiratory rate 28 beats per minute, 28 per minute. Thoracoabdominal type. Temperature was normal. Saturation was 19% on room air. His capillary blood glucose was 135 mg per deciliter. JVP elevated 6 cm above sternal angle, sir. Systemic examination, CVS examination on inspection.
So
chest wall was
did
symmetrical.
you look for what else you looked after elevation of JVP? Patient is having abdominal distension, edema. Did you look for abdominal jugular?
Sir, yes, sir.
How will you do demonstrate? How will you elicit abdominal jugular reflex?
Sir, patient in supine position, 30 degree angle, sir. Patient is inclined at 30 degree angle, and we keep the palms over the abdomen for 10 seconds, sir. And we should look for rise in JVP, sir.
How much it should rise? It should rise at
Rise,
least
3 centimeters,
and it should fall. Rise and fall of 4 centimeters from the previous thing.
Okay.
What does it indicate?
Sir, it indicates there is a right heart failure, sir.
Right heart failure. Good.
Yes, sir.
What is Kussmaul sign? What is Kussmaul sign?
Sir,
what happens to the JVP normally during inspiration?
Sir, Kussmaul sign is inspiratory fall in JVP, sir.
No. What happens to the level of JVP during inspiration? During inspiration, there will be venous pooling of blood from SCC and IVs to right atrium. As a result, the column of blood in the IJV will come down or it lowers. This is the normal phenomenon because the blood goes inside the heart. Okay.
Yes, sir.
So in Kussmaul sign, what happens? Kussmaul sign is there is a sign that seen in pathology of constrictive pericarditis or cardiac thrombosis.
Paradoxical fall in JVP.
Not have any space to stretch. The RV will have no space for stretch and accommodate the fluid blood coming from the IVC and SPC. So it cannot distend. So whatever blood coming from the SPC and IVC fills in the vessel itself. So the column of blood rises. So the rise of the column of blood in the IJV during inspiration, paradoxically, it's called small sign. It happens in consumptive pericarditis.
Okay, sir.
Yes, proceed.
Sir, examination of series inspection, chest wall was symmetrical, trachea appears to be in midline position, no precardial bulge, apical impulse not visible, no visible pulsations, no scar sinuses or dilated veins. On palpation, apex beat felt in the sixth intercostal space, half inch lateral to midclavicular line, and trachea confirmed to be in midline, no palpable sounds or thrill, no parasternal heave, no epigastric pulsation. Sir.
The apical impulse LV type or RV type? How will you differentiate?
If there is medial retraction, it is LV type, sir. If there is a lateral retraction, it is RV type, sir.
Okay. Where will you get lateral retraction and RV apical impulse?
Sir,
mostly congenital heart diseases with RV patterns. Active. Okay, go ahead.
Auscultation on mitral area, S1 S2 heard, S3 gallop was heard, tricuspid area, S1 S2 heard, no murmur, aortic area, S1 S2 heard, no murmur, pulmonary area, S1 S2 heard, and no murmur. Examination of abdomen, inspection, uniformly distended, all four quadrants moves equally in respiration, flanks full, umbilicus central and everted, no visible gastric or intestinal peristalsis, no visible mass, skin over the abdomen normal, no scars or dilated veins, external genitalia normal, sentinel orifice free.
So you're indicating what with this?
Sir, there is it could be ascites, sir.
Could be, yeah. Why are you so doubtful, man?
Indicates ascites.
It is indicating. You're having shifting dullness, no?
Yes, sir.
That means what? What sort of ascites?
Sir, the fluid could be around some 1500 ml, sir.
I don't ask a number. Mild, moderate, or severe? Lot.
Moderate.
Moderate. That's all. Yes. Proceed.
Palpation, not warm or tender. Liver palpable 2 cm below right costal margin. Firm in consistency with smooth surface. Percussion, liver dullness begins from 5th intercostal space. Liver span 14 cm. Spleen not palpable. Top space resonant note. Shifting dullness present. On auscultation, bowel sounds 5 per minute. No bruit, no venous hum, no rub.
You have mentioned your liver is smooth. Yeah?
Yes, sir.
Did you palpate?
Yes, sir.
How did you palpate 2 centimeters below costal? And you're saying firm in consistency, right? If at all you have a nodular liver, can you feel it? You get my point? Now you're saying smooth. Let us say this is a nodular liver in vachukongla. Okay? Can you feel a nodular liver with your hand? Okay, I'll make it more simple. Where do you get a nodular liver?
In case of metastasis, cirrhosis.
Cirrhosis. That's all. Simple. Simple answer is the best answer. Cirrhosis, you will have nodular liver. Okay. What will be the size of the liver in cirrhosis?
In early phase, it will be macronodular, and later phase, it will be micronodular cirrhosis.
Okay. By the time the patient comes to you, it will be late, right?
Yes, sir.
Okay. See, micro is more of a pathological thing. Okay. When you tell, so if it's going to be a nodular liver, the word usually you will use is shrunken liver, right?
Yes, sir.
Okay. So a shrunken liver is usually not palpable. Okay. You get my point? Cirrhotic liver is very rarely palpable. Okay. Where will you have a very big liver with nodularity?
In HCC, sir.
That's the answer I want. That's it. Hepatocellular carcinoma is the only condition. Apart from that, you have some more infectious causes, but one of the main causes is HCC. You will have a nodular liver. Okay. Okay. So you also have some splenomegaly is there?
No, sir. There was no splenomegaly, sir.
No splenomegaly. Only liver mattum persa irukku. Okay.
Yes, sir.
Shifting dullness is present. All right.
Yes, sir.
Okay, fine. I think you can proceed. It's fine.
Okay. Others examination, RS examination, respiratory system, bilateral air entry present, fine inspiratory grubs heard in bilateral axillary lower interscapular area and infrascapular regions. Central nervous system examination, bilateral pupil 3 mm reacting to light, bilateral plantar flexor. Patient moves all 4 limbs, and there was no flapping tremor, sir. Forgot to add that point here. Sir.
Hmm.
So this is just X-ray of the patient, sir.
Read the X-ray, Manoj. Read the X-ray.
Sir, chest X-ray, canter posterior view, sir.
Okay.
Rotated film, sir. The distance
Okay.
between spinous process and clavicle are asymmetrical, sir. It's more on right side.
Okay. What is the CTR ratio?
CTR ratio is, it will be around 0.5, sir. CTR ratio around 0.5.
So that is CTR is not increased, you want to say. Is it increased or not?
Sir, it is increased, sir.
Increased. So it is cardiomegaly, obvious. Okay, then
Yes, sir.
what about the non-vascular markings, non-vasculatures?
Point out the other shadows,
Yes, sir.
for the sake of audience. So left hilar shadow. So right heart border, show the right heart border. If it is normal or abnormal, draw the right heart border. And comment about the lung field. See, as per the protocol, you read the X-ray. Yeah.
So lung fields, bilateral lower angles could not be made out, sir. It is somewhat hazy. The patient could be in pulmonary edema, sir.
What about the left hilum? Is it free or is it occupied? Is it enlarged?
Left hilum is enlarged and
What happened to the pulmonary bay? It is obliterated. Pulmonary bay. Pulmonary bay is obliterated layer.
Yes, sir. Yes, sir.
Dilatation of pulmonary artery. So what is curly B line? Curly A line.
Sir, B lines are.
What is the normal pulmonary capillary wedge pressure? Pulmonary capillary wedge pressure, when you have that bronchoscopy marking increased. So on the pulmonary capillary wedge pressure is less than 12, mostly it is normal. So when the patient develops pulmonary venous hypertension or lung congestion, that means pulmonary capillary wedge pressure of around 12 to 18, there will be sufflation of the veins. So you will have prominent veins in the upper lobe, above. Sufflation of veins. That we call it as antler sign. Okay. Then later, about 18 to 25 pulmonary wedge pressure, you will have interstitial edema. So that is the curly B lines and the curly A lines, that horizontal lines. Okay. Then when it goes more than 25, that means frank pulmonary flash pulmonary edema, that will get batting appearance.
Okay.
இங்க என்ன பேட்டிங் மாதிரி இருக்கு, ஆல்மோஸ்ட் இட்ஸ் பிக்சர் ஆஃப் பல்மனரி எடிமா மாதிரி தான்.
Okay, but proceed.
Sir, this was the ECG of the patient, sir.
Comment about the ECG. Read the ECG as per the protocol. Starting from rate, rhythm, P wave, QRS, ST segment.
Standardization is normal, sir. Rate 90 beats per minute, sir. And there is the P wave looks normal. P wave looks normal.
Sinus rhythm.
Yes, sir. Patient sinus rhythm, sir.
Sinus rhythm. Okay.
Normal sinus rhythm, sir.
Okay.
There is left axis deviation, sir. Mild left axis deviation is there, sir.
Okay. Yes.
Low voltage complex.
Low voltage, very good. Generalized low voltage complexes.
Yes.
Before commenting on generalized low voltage complexes, look on standardization, whether it is properly standardized or not.
Yes, sir.
Right, standardization is normal. So the generalized low voltage complexes is due to what in this case? Why you are getting generalized low voltage complexes in the limb leads?
Sir, cardiomegaly.
In the limb leads, masking in the limb leads. Because of the peripheral edema, you said only bilateral pedal edema. So you get only low voltage complexes, the limb leads also. Okay. Then what else there?
Sir, P mitral.
Peace, I think, is normal, working normally. What about the precardial leads?
4-hour progression is there, sir.
4-hour progression. Okay. What is the impression? So there is a QRS widening, mild by widening. Yeah.
Yes, sir.
So what does it indicate? Old
ischemia, sir. Old anterior ischemia.
old antral MI. It's old antral MI. It's inflammation of
Yes.
old antral MI. Okay. Can you get ECG signs of heart failure? ECG, any clues can you get from any clues of heart failure from ECG?
But sir, there could be tachycardia, sir.
Okay, sinus tachycardia. Okay. Also, you can get arrhythmia also, like atrial fibrillation, EPs also. Okay, then
Sir, bundle branch block, sir.
bundle branch block. Okay.
Sir, low voltage complex P mitral.
Chamber enlargement for evidence of LAE,
RAE.
okay. RAE you will get later only if the patient has pulmonary hypertension.
Okay, sir.
Then presence of QRBB that indicates patient has developed valve dysfunction. And splinted QRS. What is splinted QRS? Fragmented QRS. These are all some of the signs. Underband black, all these things are some of the signs. ECG signs that gives clues so that patient is having heart failure and low poor progression of ROIs and all. Okay. Okay,
Yes,
go ahead.
So these are the blood reports of the patient, sir. His HP was around some 10 to 12, and hematocrit was 33.5 to 38, and his total counts were around 16,000, sir, with predominant polymorph clear cells, and his platelet counts were around 1.5 lakhs.
1 minute. Looking at your CBC, I would, looking at the platelets, can you diagnose something? Not this platelets, in general, looking at platelets in liver. How will the platelets be in liver disease?
Sir, it is decreased, sir.
Decreased. Why?
Thrombopoietin production will be decreased in case of liver cells.
Okay. Other than that?
Increased destruction by spleen, sir. Hypersplenism.
Right. So, can you diagnose portal hypertension looking at a CBC?
Thrombocytopenia.
Yes, you can. Okay. So, clinically, it's called CSP, clinically significant portal hypertension in one. Okay. So, looking at the platelet itself. Okay. So, we will look for some bicytopenia type of a picture, like anemia should be there along with platelet drop, maybe less than 30 or 25 or something like that. Patient is definitely a decompensated liver disease. Okay. So, always whenever you look at the CBC, look more into the platelets. It will give you more information regarding the CLD status. Yeah, proceed.
Okay, sir. The renal function test, urea was around 100, sir, and creatinine was within normal limits, less than 1. The liver function test, on day 1, the total bilirubin was 20, sir, with indirect bilirubin of 9.1 and direct bilirubin was 10.9. Total protein was 5, albumin was 2.7, SGOT 105, SGPT is 115, sir, ALP is 30, sir. On day 2, there was a slight rise in total bilirubin, sir, just 22. And other parameters remains almost equal, sir. SGOT, SGPT, and ALP.
Now you tell me something. What is very obvious in this? Bilirubin. Seriya? Accepted? Okay. அடுத்தது albumin. Kind of low, right?
Yes, sir. Yes, sir.
So AG reversal. Okay. So what does AG reversal indicate again?
It's chronic liver disease.
Okay. So we are on the same page. Bilirubin high, AG reversal. So underlying CLD irukku. So
Yes,
it
sir.
is not an acute event. It is a chronic event. You have just said that right now, right? So
Yes, sir.
this 1.5 months liver disease may not be true. The probably patient had liver disease prior to that itself. Okay. Looking at this one slide itself, I am able to tell that it may not be just a 1.5 month story. That's why the probing into the history is very important here. Right. So with that, we can tell. Okay. Now look at the OT and PT. Right. So finally, what have you diagnosed this patient as?
Sir, patient unfortunately succumbed
No,
to
no, no.
death,
Don't
sir.
tell me story. What is liver என்ன ஒரு diagnosis சொல்லியிருக்கீங்க?
Ischemic hepatitis, sir.
Ischemic hepatitis. What are the essentials of diagnosis for ischemic hepatitis?
Sir,
மூணே மூணு
OTPT
மேட்டர்
more
தான்.
than liver
சொல்லுங்க.
enzymes OTPT more than 1000, sir.
more than இல்லை, in thousands.
Okay.
Okay, அடுத்தது என்ன வேணும்?
Sir, AST by ALT ratio, sir.
Okay. எவ்வளோ
More than
இருக்கு?
2. More than 2, sir.
Okay, right. Then LDH. Have you done an LDH for this patient? No.
Sir,
Yeah, you have done? I was not able to find it anywhere. Was it done?
no, sir.
Okay, fine. What about it? ALT LDH ratio should be less than 1.1. AST must be usually in thousands, but in this case, it's always been in 100, 137, 123, right? It is
Yes, sir.
more towards alcohol rather than ischemic hepatitis, right? Okay, proceed.
Okay.
We'll catch it in the next slide. Yeah.
1 minute, Dr. Dave. Sorry to interrupt. From this slide, the total protein is 5, albumin is 2.7. So still albumin has not taken over this globulin, I think so. Because globulin is 2.3. 2.3
Okay, 2.3.
only.
Okay. So
It has
full
not
age
crossed
reversal
that
has not
limit.
happened.
It is not that much chronic, I say.
Okay,
And
fine.
by looking at these values, SGOT, SGPT, these are raised in hundreds. So it is again an indicator of chronic liver disease. So it may be a borderline chronic liver disease.
Borderline,
Not that
alright.
much of chronicity. I think so.
Point taken, sir. Point taken. Okay.
Yes, proceed.
Nice, sir.
Manoj, can you just go back about the renal function?
Yes, sir.
I'm not very much convinced with the values of renal function for the 3 days. When you have somebody with a BP of 80, 90, what is the output for the first 3 days?
Sir, output was
Normally, we don't see this kind of readings, particularly in patients with a decompensated heart failure. Usually, maybe first day I'm okay with it, but I still have a doubt with the second and third day. With the values here, when you have a BP around 90 to 100, even with the 2 inotropes, I'm not 100% sure exactly what this indicates. And what is output for the first day, second day, and third day? Do you have any idea about it?
yes, sir. His input intake was around 800 ml, sir. 800 to 1200 ml, sir. In the form of inotropes, like that, sir. He had an output of around some 600 ml, sir.
Okay, so because the values not fitting into the clinical criteria, particularly when the patient has this much of BP, like a decompensated heart failure, we normally see elevated creatinine on the second day or third day. Definitely, particularly in this type of patients. You don't see normal creatinine. I think here there should be a lab error. No other way you can explain normal creatinine on the second day and third day, particularly with the BP of around 90 and with the output of like 600. Balamurugan, are you agree with it?
Yes, sir.
Because when you have this much of urea, so that can indicate your melena. That's one of the other reason, and then the dehydration and sepsis. But still, I'm worried about the second and third day of creatinine. So I think that probably lab error. I think.
Can it be cardiorenal?
Yeah, I'm thinking of cardiorenal because we don't see normal creatinine on the second day and third day, isn't it? With that much sick patient in ICU, with the 2 inotropic supports. But yeah, I can see Kannan Baba saying sometimes the creatinine can be low in this one, but I still can't get it right in my head because of that low BP with the 2 inotropic support, and it is still around 90 to 100. Okay, let's go on. Yeah, that's fine. Yeah.
Shall I proceed, sir?
Yeah, go on.
Yeah, please go ahead.
These were serum electrolytes values, sir. Sodium was on the lower side, as well as with potassium, sir. It was around some 120, and on day 3 it improved. Potassium was around 3, sir. ESR was 19, CRP was positive.
One
Viral mark.
question about the low sodium. How do you treat this low sodium in this kind of patients?
So fluid restriction, sir.
Okay. Anything else?
Can advise increase salt intakes.
No, that's not a good idea, particularly when you have the fluid overload. We nowadays use
Diuretics.
Diuretics is going to decrease the sodium. What they do? What do they do, the diuretics?
Hyponatremia will worsen, sir.
Any other drug?
Any other drug that we use
in cardiac failure
nowadays? Cardiac failure with low sodium. It has a two advantage. One, increasing the sodium. Another one is increases the diuresis. We have a drug now.
Sir, SGLT2 inhibitors.
No. 12-octane. So have you heard of this tablet?
Sir. Yes, sir.
Yes, it's very good now because sometimes people use 3% NaCl. We can't use in heart failure patients 3% NaCl. But the 12-octane, as I mentioned, it also increases your sodium and also it produces a natriuresis. So you have a diuresis also. So that's one of the drug now we commonly use in patients with the heart failure with the low sodium. Yeah, go on.
Okay, sir. ESR was 19, CRP was positive, 19 in 1 hour. CRP was positive. Viral markers, hepatitis B and C, both were negative. ICTC was non-reactive. Urine routine, albumin, sugar, and deposits were nil. Stool blood was positive. Both blood culture and urine culture had no growth, sir. So this was the coagulation of the patient. PT was around some 35 seconds, and APTT was 34 and 39 seconds on the 2 days. INR was around 2, sir. Ultrasound of abdomen and pelvis. Impression given was mild hepatomegaly with mild to moderate ascites, sir.
Kidneys. Kidneys. What about the kidneys?
So kidney size they mentioned as normal, sir.
Okay.
Echo was done and it showed a global hypokinesia of LV with ejection fraction of 30%. Severe LVSD was there. Interventricular septum thinned and scarred. LV was dilated. All 4 chambers dilated. There was moderate MR, moderate mild regurgitation and tricuspid regurgitation with TRPG of 35 mmHg. And TAPSI was around 14 mmHg, sir. There was mild to moderate pulmonary hypertension. So we obtained MG opinion, sir, which suggested could be a case of ischemic hepatitis, and they suggested lactose syrup and NSL16 injection, sir.
Yeah, just 1 minute. I would like to differ. They said ischemic hepatitis, right? So
yes, sir.
What is the base? One thing I told was the value should be in
thousands. OTPT
right?
should be in thousands.
Yeah, so it doesn't fit into that. That is the basic criteria. One, all right. But given the backdrop that there is a major cardiac event happening here,
Yes,
it favors more towards ischemic hepatitis. Okay. By the way, it's no longer called ischemic hepatitis. It's called
cardiac cirrhosis.
Yeah, cardiac cirrhosis. It's no longer called
Congestive
ischemic.
hepatopathy, sir.
No. That is another terminology altogether. That's another topic. Here there is reduced supply to the liver. Congestive hepatitis, too much of blood is there in the liver. You get the point? It is called hypoxic hepatitis. The terminology has changed now. Okay, it's called hypoxic hepatitis or shock liver. That's how we say it nowadays. Okay. So one thing which I will think is why the transaminitis was not in thousands. There are only few conditions where the transaminitis will go to thousands. Can you tell me? 4 conditions.
Sir, toxic hepatitis, sir.
Toxic, na? What do you mean?
Toxins are in case of rat killer paste poisoning.
Okay, toxin induced. Okay,
toxin induced.
I'll take it.
Hepatitis A.
Viral hepatitis. ஒரே வார்த்தை. Okay, அடுத்தது. இது சொல்லுங்க. இந்த diagnosis என்ன? Ischemic hepatitis. Okay, or hypoxic hepatitis. Then, so I remember it as like this. VADI. VADI. Okay. V is for viral. Viral hepatitis. A is for autoimmune. And even sometimes, not always, alcohol hepatitis. Not always, sometimes. Okay.
Okay, sir.
B is for drug induced. Drug induced can be medication as well as your rodenticide, paracetamol, all this. I is
Okay,
for
sir.
ischemic. So Vadi, remember 4 conditions where you will have in thousands. In alcoholic hepatitis, it will not go to thousands. It will never cross 400. Okay.
Okay, sir.
So always keep this in mind. So I care to differ in this, but only thing is because the backdrop is there is a major cardiac event happening. So one diagnosis you can think is ischemic hepatitis. The other differential I will give is ACLF. What is ACLF?
Acute on chronic liver failure, sir.
Okay, what is the definition for ACLF? It actually fits in ACLF a little bit, if you note. Have any idea what is the definition? Okay, I'll tell you. So basically, ACLF is actually a reversible syndrome where the patient presents with jaundice as well as coagulopathy, which is evidenced by bilirubin more than 5 and an INR more than 1.5. Okay, and the patient should, which is followed by ascites. The patient may or may not have encephalopathy and may be associated with AKI. Okay, and all this can happen in a patient who is already diagnosed or undiagnosed CLD. So according to our case, in this case, patient is already having bilirubin more than 5, that is jaundice. Patient is having coagulopathy, INR is elevated. Patient is having ascites also, right?
Yes.
Patient doesn't have and or, it's called and or HE. So HE doesn't, hepatic encephalopathy doesn't necessarily have to be there. And
Okay.
another thing is may or may not be associated with AKI. So I would like to think this can be an ACLF, that is an acute on chronic liver failure. That is one of the differential diagnoses I would like to do it. But the only thing here which is not in favor is the liver should be a cirrhotic liver, but here your liver is almost normal, right? So taking the backdrop as a cardiac event, I will vote ischemic hepatitis or hypoxic hepatitis as number 1. Second thing, I will closely say ACLF could be the thing. So the acute event could probably be chronic alcohol intake. So recurrently for 10-15 years, he has been using ethanol. So naturally, he could have gone for multiple episodes of alcoholic hepatitis. So that would be a baseline where there is a liver damage happening. Now, because of this ischemic event, because of this cardiac event that is happening, the liver is full blown gone into a failure. But again, it is not favoring because ischemic hepatitis transaminase will rise to thousands. It will be there for 3-4 days and then rapidly it will fall once the cardiac status improves. You get the point? So keep
Yes,
ACLF as a second diagnosis. Okay? Yeah, carry on.
Yeah, at this juncture, Babaji, Kanan Babaji has raised a valid point in the chat box. So to all the participants, please note it. So that is really a valid point because we are discussing that whether it is a pre-renal or it is a AKI or it is a cardiorenal or it is a laboratory error. So we are discussing that. But this point is to be taken into account in the presence of high bilirubin. So bilirubin always negatively interfere with the estimation of creatinine through some oxidation process, I think so. So high bilirubin may interfere with the creatinine estimation, leading to falsely low value. So here the persistently the urea is elevated. So we have to consider that point also. It may be a problem of cardiorenal, especially type 1, because of the persistent hypotension. And we have to consider other markers also, whether the patient is having persistent oliguria or increasing this hypotension or pedal edema, facial puffiness, and raising urea level. So you have to still follow the patient for further day, 1 or 2 days, or repeat estimation. So that will give you some spotlight on whether this is a cardiorenal or something else. So that is a valid point. Thank you, Babaji. So okay, you can proceed. And that is a point for this gastroenterology question also. If that is going to be a cardiorenal, so why can't it be it is a cardiac hepatitis or ischemic hepatitis? So that is my question also. Okay, proceed.
The course in the hospital, patient was treated as a case of acute decompensated heart failure with hypertension and ischemic hepatitis and was treated with nasal water, IV antibiotics, heparin, antiplatelets and statins, lactose syrup and bowel wash. He was started on inotrope support, including dopamine and noradrenaline infusions. with continuous vitals monitoring. Baseline investigations revealed deranged liver function test with markedly elevated bilirubin and transaminases, consistent with ischemic hepatitis. Despite adequate inotrope support, patients' blood pressure remained low and ultimately succumbed to death.
My question here is, was a portal vein Doppler done?
No, sir. Since
Why
the
am I
patient
asking for a portal vein Doppler here?
look for portal vein thrombus, sir.
Okay, because patient is having CLD. Anything else? I want to see if there's any portal hypertension happening. Right? Another thing I
Yes,
would
sir.
like to look is I would also want to do a UGI scopy or something like that.
Sir, since the
Because,
patient
yeah,
was in shock,
the patient was very sick to be moved for a UGI scopy. Because
yes, sir.
a simple UGI scopy can actually tell us whether there were any esophageal varices, whether there was any portal hypertensive gastropathy, what was the cause for melena, was it a variceal bleed, was it a non-variceal bleed? We don't know now finally we don't know why the melena happened. Probably it can be because of drug also, because the patient has been taking some heparin and all that. So maybe because of drug induced stuff, we don't know exactly, because the workup was little more, if we had gone into the workup, probably we would have got it. So I think we have to ascertain the reason for the bleed. Then we can finalize whether it was a DCLD case or a ACLF.
I think I would probably go more for a DCLD than acute, the
Okay.
values and everything.
Mm.
Maybe, as you suggested, acute on chronic possibility,
ACLF,
but I don't
that's
think so. It is only an acute hepatic liver injury.
Yes, sir, you're right, sir. Because now, as Kannan Baba sir has said, it probably there was a renal component happening. We were just looking at the creatinine, and probably I was looking at the creatinine and thinking creatinine is normal, so probably kidney is nice, it's okay. But the urea was constantly elevated. So according to the ACLF definition, apostle guidelines, it classically fits into ACLF. The acute event being probably a chronic subtle DCLD event happening, and now a full-blown event because of the cardiac, because
No,
of the
I
ischemia.
would have to say, because here I don't think so. Cardiac cause is the only cause for his death.
Yeah.
I think it's
Yeah.
a multiple problem at this stage, because we are seeing patients walking up and down with the EF of 30. They are
Okay.
not going to suddenly come to the hospital with this kind of problem if they have only cardiac issue.
Yes.
I think here is the sepsis is also the problem,
Yes.
because you can see that 100% neutrophils and all, and also probably acute on chronic decompensated liver disease.
Liver disease, yes.
Because as I said, 30% of EF, unless there is something acute ischemic cardiac happen at that stage with the background of 30%, then we see this kind of cases.
Exactly.
But just at 30% EF, they are not going to come to your OPD with a casualty like this sick. So I don't think so. It's a pure cardiac.
Underlying liver has been there, sir.
Yes,
There is some underlying liver event happening.
Definitely. I think something is actually, I would say, ignited all these problems. Maybe the sepsis.
Yes, sir. CRP is also positive. So probably there is a sepsis component also there.
See, I think he was managing with the DCLD and also with the 30% EF. So this is a problem, because it already has a multi-organ problem. That's the one thing I think brings everything down is always the sepsis.
Sepsis, yeah.
Because you have this inflammatory markers high, they produce all sort of sympathetic stimulation and all these things, and then they suddenly go for a worsening of the heart problem, and they'll go with the hypotension. And then the hypotension are all the circles again, like ischemic on long-term chronic liver disease, ischemic renal impairment, whatever they have before, because they are going to have a reduced renal function already anyway, because of the EF of 30. With this single problem, the sepsis actually make everything worse at one stage, and then they will have a problem like this. That's the kind of patients we see. Sudden deterioration is 90% of the time is due to the sepsis. So I would say that all the others, if they come with the worsening of the heart failure, 90% of the time they will survive and go home. I think the problem here is the sepsis and the liver. Maybe the bleeding might be an acute event here. So as you said that we have not done the OGD, he might be having some variceal bleed there. And the sepsis. Everything actually probably was in the heart function also. Even though it says 30, I think it's everything goes with the sepsis and the worsening renal function and the hepatic function. Then the cardiac function is not able to tolerate the whole thing, and then they suddenly collapsed.
Yes, sir. That's what I feel. Probably it's because it was a ticking time bomb, sir. Already the liver has been decompensated. The final nail in the coffin was this event that has happened now.
The event, yeah. That's what I think. I think the one thing is brought everything down. To pull the curtain down, and then he suddenly succumbed. But that's only because he's only 34, isn't it?
Too young for
too young to have.
But again, chronic alcohol, I mean, intake of ethanol has been for 10 years. We don't know how much exactly. I'm sure these people would have, I'm sure it could have been a variceal bleed, sir. I'm sure it probably
definitely. And then I would say the low ejection fraction may not be only related to his heart. It may be related to the alcoholic problem also, cardiomyopathy also.
Cardiomyopathy, yeah. Okay.
Can you have this much high bilirubin in sepsis, sir, about 2019?
Yes, sir. Possible, sir. Possible. Sepsis-induced hyperbilirubinemia is very common, sir. And in this case, lot of issues are there, sir. Hyperbilirubinemia or alcohol intake, multiple components. The variables, the confounding factors, so many are there here. So we can't pinpoint it. It's just because of this, the bilirubin is high. So it can be, but definitely sepsis is because CRP is positive, leukocytosis is there, patient has been on inotropes. Taking everything into consideration, probably patient sepsis had a role to play with this also.
I have seen this much of bilirubin recently in one of my cardiac patients. It's a decompensated heart failure. He survived and went home. He didn't have any other previous issues like with his liver. So I think it's here he's not recovered is because of the acute on chronic. That is the issue here.
Acute on chronic, yes. Actually, the treatment part in ACLF, I used to always have an argument with my cardiology counterparts. The treatment for ACLF is give lot of fluid. Yeah, but cardiologists will be catching my throat and say, don't give fluid, man, he'll die. So we are always having this dilemma happening.
That is the problem because when you want to give a fluid, if already 30, what we normally worry is if he goes for a pulmonary edema, he suddenly die.
Exactly.
Because you may not even have a time to intubate him.
Exactly. But it has always been a dilemma how to deal with the situations because fluid will help push out toxins and all that. But as you say, sir, flash pulmonary edema, nothing can be done.
Nothing. It just goes off suddenly.
Exactly.
So my question is to Dr. Davis. So what is your experience on these types of cases, cardiac hepatitis 1? And then question to cardiologists. So your experience on the cases like cardiac hepatitis or cardiorenal syndromes, have you ever come across these situations? Because how can you save these types of patients? Because the decreasing BP, whether it is due to sepsis or cardiac problem per se, because worsening DCM, so worsening EF is getting low and low, and BP is getting low and low. And what is meddling is what is annoying is the bilirubin level. Bilirubin level is enormously being elevated day by day. And to add to our woes, there is a urea is also getting elevated. So in these types of cases, how can we save the patient in tertiary care setup? So can we go for this device therapy or any newer drugs to treat failure in the presence of jaundice? In the presence of jaundice, what are the drugs to be administered for failure? So these are the questions to gastroenterologists and cardiologists.
I think I would answer about the device. Device has no role in these acute situations because they are all only for the stable patients. Hemodynamically stable patients only we can try the device, and particularly in this scenario, the device may not be helpful. We have a situation, acute cardiac situation, we have a device therapy, but not for the this kind of patients. Second, I think from the cardiac point of view, as I said, because we have to treat the sepsis with the higher antibiotics and then give a support to the heart, like hemodynamic stability with the inotropic support. And if you want to give diuretics, now what I normally do is I start both the diuretics and the Lasix infusion. So it may not reduce your BP suddenly with the Lasix infusion. So this kind of patient, we have a couple of patients recently treated with myself and nephrologist. That's what we did. I think luckily both of my patients survived and then went home. As I mentioned that because that patients, they did not have any other comorbidities like previous renal function normal and then the liver function was also normal. So with this scenario, it is always difficult to predict what will happen until we control everything. So cardiology point of view, I probably may not be able to do anything more than what you did, but the sepsis wise, I don't know what kind of antibiotic he had. Maybe as a private, we normally the nephrologist suggests high dose of antibiotic like meropenem or Piptas, that kind of antibiotics. I don't know what type of antibiotics he had in this case.
Okay, so any remark from any participants, any questions?
Whether excessive use of diuresis might have increased the urea to nephrologist, Dr. Kanan Baba.
Yes, he has already opened in the chat box.
Diuresis has increased there, or whether restricted diuresis might have brought the urea down.
Diuresis will increases the urea. Yeah, diuresis will going to increase the urea level.
That's why I'm asking whether in this case use of diuretics have increased.
Yeah, by concern when we go through all these slides, in my view, there's a high rise in the urea maybe due to this protein catabolism in the bowel. There's a patient having some upper GI bleed, the protein catabolism, the reabsorption of the urea, and the patient with hypotension and the features of cardiorenal syndrome. As well as the sepsis, all these conditions will there will be a rise in the urea level will be there. And my opinion, the creatine, there will be some underestimation of the creatinine values when considering the high bilirubin. These are all some of the reasons. And this exactly this problem fits with the underlying sepsis. So I vote for the sepsis in this case.
Yes.
So to answer your question regarding how do we deal with the ischemic hepatitis, we frequently get callovers to the CCU saying that we have transaminitis happening. So our goal, actually transaminitis, if it is going to be a pure case of hypoxic hepatitis, it's actually very easy to treat because we don't do anything there. Once the cardiologist starts them on good inotrope and improves the cardiac function, automatically in day 2 or 3, the liver comes back to normal, the transaminitis comes down, and we actually see a good improvement happening. The role we actually play is we try to rule out other conditions like ACLF, a DCLD who has ended up in an ischemic event like this, or any other problem that has worsened it. If it is going to be an ACLF type of a picture, then it becomes a headache for us because mostly the patient will be bleeding because of, like as in this case, melena is happening. Sometimes the patient can have hematemesis. The cardiologist will say the CAD is happening, we have to start heparin. So that's where the argument comes. We will be like, he's bleeding, you can't give heparin. The cardiologist will be like, no, we have to give, otherwise the heart, we can't save the heart. So this sort of a complication only we frequently frequently encounter here. So for these patients, we try to do an interventional procedure like an endoscopy. We try to locate the source of the bleed. We quickly try to put a band or at least an adrenaline injection or at least a glue therapy, something we do to stop the acute bleed. Because, and unusually in our case, this case per se, the patient did not have much of hepatic encephalopathy despite having such high bilirubin levels. That is quite unusual. Usually the patient will have some sort of hepatic encephalopathy component also. So that is the reason they have started lactulose and all that, I believe, looking at the bilirubin values alone. but in this patient, there is not much of HE. So if at all we go to the CCU, we try to control the bleed aspect and we keep monitoring the LFT. We did have one case where we were not able to do. For that patient, we had to do a bridging therapy and we sent the patient for liver transplant. That was the only way we could save the liver. So in worst case scenarios, we use all these techniques as a bridge therapy just to send the patient for liver transplant.
Okay, thank you, Dr. Davis. So, shall we summarize? Are any other questions, doubts from the PGs or other participants? Right. So, we'll close this session. So, this case is having a burning cardiac problem in the form of as a DCM, PTCA done, and persistent hypotension, worsening hypotension. That is one side we have one problem. So, another side, worsening liver function also, deteriorating liver function and raising bilirubin, enormously raising bilirubin. And another problem is we have this sepsis, right? Sepsis markers are increasing. So we can vote, finally we can vote for sepsis, but there are things unresolved even after the death of the patient. The first thing is the cardiac problem is there, the hepatic problem is there. Whether we may have diagnosed this case as a chronic liver cell problem, but it may be a chronic liver cell problem, but sudden catastrophe, right? Sudden deterioration in liver cell function, sudden deterioration in this cardiac function. So what is the answer? So the sudden deterioration is in the cardiac, hepatic liver cell problem, or sudden deterioration of the renal problem may be due to this cardiac problem. So that may be the answer. Cardiac problem would have caused sudden deterioration of the liver cell problem. It may be a chronic problem, as Dr. Davis opined. It is an acute and chronic problem. This acute deterioration may be due to cardiac decompensation. So that may be the answer. The cardiac decompensation would have been caused by the culprit, the sepsis. But how to treat this patient? Till you spot the convict in any murder case, the suspect becomes the culprit. So that is the answer for this case also. Till we get the answer, we don't get any answer. So till then, you treat the suspect. Suspect is a cardiac. So cardiac problem, you have to treat. You have to treat hypotension. You have to treat. You have to use this inotropes or diuretics. It is a balance. It's a walking on a sword like this. You have to take decision. So in this case, physician has to take the final call. So cardiologist will look at the heart, hepatologist will look at the liver. So the holistic approach, the final decision has to be taken by the physician. So we had a very good discussion, and thank you, Dr. Balamurugan, Senior Assistant Professor, Dr. Badasha, consultant cardiologist from Tirunelveli, my close friend and my best friend, and Dr. Davis, always my pet student, my pet assistant. Now we're a great consultant gastroenterologist, Chennai, budding consultant gastroenterologist, and of course my ever friend Dr. Babaji is a master of all subjects. Whatever case is presented, he will hit a sixer in
Thank
any
you, sir.
So
Thank you, sir. Thank you, sir.
Thank you all,
I want to
friends.
add a word. After a very long time, I had a very beautiful interactive session. The moving away from the Thuthukudi to Tirunelveli, automatically I lost the touch with the general medicine subjects from the 2021 I moved here. I think we will continue the session. We will, it's very interactive. I think I lost this golden period in Thuthukudi Medical College where we have a beautiful discussion in the physician conferences. I missed all this brainstorming sessions since 2021. Anyway, thanks Rajavel sir for this beautiful initiative.
Thank you, Kannan Babaji.
I
So
just
we'll
want to just appreciate Dr. Manoj. You have done an excellent presentation. Just make sure you fine tune into the history. Being a student of medicine right now, you have to probe into history. Otherwise, you have done a good job. Okay, keep doing well and keep improving. And thank you, Rajavel sir, for giving me this chance. It's a very humbling experience. I know I don't deserve all this, but still you have given me a chance to teach something to the students. Thank you again, sir.
Thank you all.
Thank you, sir.
Good night,
Bye.
Okay, bye.
Bye.
Right, sir. Thank you, sir.
Bye.
Thank you.